Picture on the right, this is a functional MRI. It looks like a beautiful piece of artwork, and it is, right? So it's the brain, but it's a real image of a functional MRI. So let's kind of look at this here. This light blue area down here, I'm going to draw over it in light blue so you can kind of see where my cursor is. So this area here, okay, on the lower side there, I'm going to erase it so you can see the original drawing now. So that it looks to me to be the pyramids of the medulla. So how do we know that? We want to check our bearings here and look at this red area. I'll point an arrow at it. There you go. This red area here is the pons. Okay, so we can tell that this is the pons coming here, and then we could see that these would be the cerebellar peduncles. Okay, so it kind of looks like a flip hairdo, like Mary Tyler Moore. Remember that hairdo? And so that tells me that this area here is the pons. So I'm going to go ahead and erase that so you can see the original functional MRI without my drawing on it. Because the colors and the lines do mean something. It's the direction of flow, of energy of the brain here. So we could see here the pyramids of the medulla. And then what tracks do you think this might be? What tracks might be going through here? That sure looks like corticospinal tract to me. So corticospinal tract would go through this area here from the cortex and then descend down through these pyramids of the medulla. And you could see, I'll erase my drawings as well. So some of the light blue up at the top and then coming through and into those pyramids there. So that's how we can trace that. So kind of a neat picture there. All right, so our brainstem. So let's get back to our basics here. Our brainstem, midbrain, pons, medulla. Okay, we have that drilled into our brain. Right? So from inferior to superior would be medulla, pons, midbrain. Okay, so midbrain, the chapter 2 embryology of Nolte tells us that midbrain is mesencephalon. And medical terminology is going to tell us that too, right? So mes means middle. Okay, so encephalon is brain. So cephal means head. En means what's within the head. That's the brain. Okay, so midbrain is what that word means. Even if we never saw it before, if we just took medical terminology, we could figure that part out. Remember that that midbrain does not differentiate. So if we look over here, midbrain over here, midbrain over here. So our primary vesicles on this side, prom-rom, P-R-O-M, right? And then rom, prom-rom, prosencephalon, mesencephalon, rhombencephalon. Differentiates out into tel, di, mes, met, my is the little sing-song way to remember that. So our prosencephalon is going to be telencephalon and diencephalon. Mesencephalon does not differentiate out. That's going to just be midbrain. Rhombencephalon is going to be met and my. And down here on the table, you can see where met and my are going to become the pons and cerebellum, and myelencephalon is going to be medulla. Okay, so we're here on this chart, here and below. We're going to see 10 of our 12 cranial nerves in the brainstem as well. So 1 and 2 are not going to be in the brainstem. Those are going to be higher than the midbrain. And I'll show you an easy way to remember that when we draw out our cranial nerves. It's called the rule of 4s. Okay, so we're going to see 4 in the medulla, 4 at the pons, and then 4 at the midbrain and above, because 1 and 2 are not at the midbrain. We'll look at that again. So basics here, the brainstem is going to have conduit functions, cranial nerve functions, and integrative functions. So we're going to separate those 3 out and kind of look at that. 1, conduit functions. Here's another picture of that functional MRI with just the corticospinal tracts kind of teased out there, and we can also see the corpus callosum is that nice pink U-shaped there connecting right brain to left brain. So Nolte tells us the only way for ascending tracts to reach the thalamus or cerebellum is, or for descending tracts to reach the spinal cord is to pass through the brainstem. So it's this pathway, it's a passageway. Many of these tracts, however, are not straight through affairs, and there are identifiable relay nuclei in the brainstem that are frequently involved, and we'll get into those specifics in this chapter. Cranial nerve functions. This is a very important picture to look at and understand. So when I test on this, I don't test on each and every one of these, so don't get too intimidated by it. When I test on it, I pick some of the big ones here. So if you look, this principal trigeminal nucleus in the same color that I just highlighted here, check out how high that goes. Okay, so this trigeminal tract through here, note that it's not just going to be for cranial nerve 5. Okay, so when we look at these, I want you to kind of think about what we saw in chapter 10 with the tracts. So we're going to start to see these cranial nerves and their nuclei a little bit differently than just the nerves to and from the face. We're going to look at them as these tracts in the brainstem as well. So another little one I want to show you here, I don't necessarily test on this one, I just want to show you where trigeminal is mentioned here again. So if you look for orange, my moving cursor there, okay, you can see the trigeminal motor nucleus over here. Okay, so trigeminal sensory of face, way more territory. Trigeminal motor is going to be mostly for chewing, so it's going to not need all of that real estate, right? So what other ones do I like to point out here? I like to point out Edinger Westphal up top here to the left. You can see my cursor moving in orange. Look at this little guy right there. Okay, so Edinger Westphal, remember, is going to be for pupil control. And check out where he is. This is important. It'll help it make sense. So I'm using my green to circle. What are these two bumps here? Yes, superior colliculus, right? And then the two bumps below it, inferior colliculus. Superior colliculus, what's its function that we memorize? Visual reflex, right? So we see something out of the corner of our eye and we turn and we look. That's being controlled by superior colliculus. So eye stuff, right? So Edinger Westphal being part of that pupillary response, makes sense that it's hanging out by superior colliculus. And then if you look to the right there, we could see that bigger red guy here. That's oculomotor nucleus. What cranial nerve number is that? Yes, 3. So again, makes sense that it's hanging out with superior colliculi area here. So I specifically point out those, and then I want to also point out vestibular cochlear here as well. So vestibular cochlear. So vestibular for balance, right? And then cochlear for hearing. So check out how much real estate that's taking up there. I'm going to go ahead and erase my markings on here so you can see it clearer. Good. So make sure you look at everything else as well, but sometimes these pictures are intimidating. So what's the first thing I want you to really get out of this? And then you can start to kind of piece out what the rest of this means, right? So this here, rhomboid fossa, that's the floor of the fourth ventricle. We can see the cerebellar peduncles here, so the cerebellum has been cut away. And so then we would see this being medullary. We would see this being as midbrain. So the in-between area would be that pons. So we're going to look at this in depth in chapter 12, but we want to kind of keep an eye out for what our when we're looking at these cranial nerve nuclei, again in chapter 12, we want to know what our cranial nerves do, right? So we have 12 cranial nerves. Little intro here. We've got olfactory and optic. Okay, so olfactory, optic, ocular, motor. So we have the 3 that start with O. O, O, O. T, T, A, F, V, There's a million mnemonics out there. I'm not going to say them on any recording whatsoever. There's a Harry Potter one. You can check that one out. We go into that in chapter 12 in depth, so we'll get all of that. The one quick, easy way to do this, though, is look at these O's, right? So we have one nose, two eyes. Okay, so one is olfactory for smell, and then we have two eyes. So we have one nose and we have two eyes. That's pretty easy. Oculomotor, ocular is for eyes, and then motor is movement. So this third one is for eye movements here. And then you can go on down the list here. So 4 is trochlear. This is going to be for superior oblique. So we'll see this mnemonic SO4, LR6, all others AO3. So superior oblique is going to be cranial nerve 4. Lateral rectus is going to be cranial nerve 6. All other eye muscles, including pupil, is going to be cranial nerve 3. Okay, so we'll say that over and over and over and over and over again until you hear that in your sleep. Okay? So 3, 4, and 6, eye movements. 2, sight. Okay, so cranial nerve 2 is sight. 3, 4, and 6 are for eye movements. Cranial nerve 5, general sensory nerve for the head and also for muscles of mastication or chewing. And then, so 3, 4, and 6, eye movements. Okay, 7 would be facial nerve. So our sensory is going to be the face, basically. Okay, so external auditory meatus, sweet taste in the mouth, so the anterior 2/3 of the tongue. Again, we'll go into major detail in chapter 12. These are just the basics to kind of get you started. Motor is going to be face, so tears and saliva are going to be facial nerve controlled as well. Number 8, vestibular cochlear, so hearing and balance. So vestibular, balance aspect. Cochlear, hearing. Think of a cochlear implant. Glossopharyngeal, gloss means tongue. Pharynge would be a part of the throat. So this makes sense that its main function we think of is motor, swallowing, and gag. Okay, so sensory is going to be for carotid sinus, carotid body, so blood pressure, blood issues coming up to the brain. Bitter taste in the back of the tongue, so we say bitter back 9. 7 sweet, bitter back 9. Again, this is just the intro. You don't have to worry about memorizing this yet. I just want you to hear the words. We'll get all of the memorization and little pictures and things to help in chapter 12. Cranial nerve 10 is vagus. So vagus means wanderer. It wanders all the way down through the internal organs of the body. It's also going to be a component of the throat and for the gag reflex as well. So 9 and 10, think swallowing and gag. And speech. Cranial nerve 11, spinal accessory nerve. So this is going to be for SCM and upper trap. So it's that turn and look. So think about that superior colliculus again. So the visual reflex center where we see something out of the corner of our eye and we turn and look. We're also bringing our shoulder up in order to protect. So we think about spinal accessory when we do that. Hypoglossal, swallowing and gag, and speech. So this is tongue. We stick out our tongue in order to check out the hypoglossal nerve. So I starred these for you so you could see the ones that I test because again this picture gets very intimidating at first. So I showed you what this looked like on the other view, okay, the PDA view that we were looking at, and now we're looking at a lateral view. So you could see the nucleus of the oculomotor nerve in red here, and then you could see oculomotor nerve fibers coming out. That's what those red fibers are there. You could see the Edinger-Westphal, so theme calls it visceral oculomotor because again, remember we're getting rid of eponyms or naming things after people's names because it doesn't help us in understanding it, right? But visceral ocular motor sure helps us in understanding that this has to do with pupil response, okay? Parasympathetics. And then moving down, you can see all the way down to the yellow Okay, we're going to look at that spinal nucleus of the trigeminal nerve. So this trigeminal nerve, to me, I liken trigeminal nerve nucleus, okay, so spinal nucleus of the trigeminal nerve, to spinal thalamic tract. Okay, so touch pain temperature of the body, spinal thalamic tract. Touch pain temperature of the face, the head, is going to be trigeminal. Okay, so if you look, it's all the way down here, right? So we've got this nuclei. I've got my yellow marker here to kind of guide us. Look at how far up he's coming here, right? And then out, and it's that gigantic nerve that we saw in the lab videos and in the lab someday, right? So we could see that, and we could see mesencephalic nucleus of the trigeminal nerve. That means that it's midbrain. So where is the midbrain? We look for these colliculi right here. And so I'll switch to red so you can see it a little bit better. So superior colliculus, inferior colliculus, cerebral aqueduct, connecting that third ventricle up top to the fourth ventricle right here, cerebellum right here. Okay, so mesencephalic tells us that it's midbrain, and it is in the midbrain. See where it's starting in the midbrain there? So we've got our midbrain markers right here, and then this circular bump here, that's the pons. And then when we see below that, we've got medulla, right? And then spinal cord. So taking this little bit by little bit here, and then it's a little less intimidating. Okay, so the first things that we want to see here are the nucleus of the ocular motor nerve, this top red guy. And then we want to look at Edinger-Westphal for the visceral ocular motor and the nerves going to that. And then we want to see that it's on level with this superior colliculus of the midbrain. We can see inferior colliculus here, but we can see the cerebral aqueduct. This is important, right? Because if this gets inflamed and there's too much pressure here, right? So fourth ventricle, we're okay here. If there's a little bit of extra pressure, I mean, it's not good to have extra pressure anywhere, but if we have a little extra pressure here, it's not going to create such a deficit as it would in this tiny little tube of the cerebral aqueduct. Okay. So that's why we check eye movements when somebody gets hit in the head. Like on the football field, you see them first saying, okay, who are you, where are you, what year is it? That's the mini mental exam. Okay, so alert and oriented times 3 is what we say if they pass that. Then you're going to see them say, follow my finger with your eyes. And what that's going to tell us very quickly is there inflammation in the brain? Is there an excess of cerebrospinal fluid starting to form and fill up? And this tiny little straw here would take the hit first. So we'll see that press on the cranial nerves for our eyes here, right? And then look right here, that's cranial nerve 4. Okay, nucleus for cranial nerve 4. And he comes back out this way, remember, and then loops around. So you can't see him looping around, but pretend he's looping around the front and out. So he exits posterior that way. So we would do AO3, all others, right? All of our eye muscles, including pupil, right? So including our pupillary control. So LR6 and SO4. So this is the SO4. Superior oblique is going to be controlled by this guy right here. And then a little further down is 6 right here. And so he's a little bit more protected because there's a little bit more room here in the ventricles. But that 3 and 4, that's going to take a hit pretty quick. Okay, so understanding our structure helps us understand our function and our dysfunction and why our eye movement testing is so important. And then the other one here, again, that I wanted to reiterate that we're studying is this yellow guy here, looking at this massive amount of real estate that trigeminal is included in here. Okay, so trigeminal. So think of that again as like spinal thalamic for the face. And then as we get into the rest of these nuclei, we'll go through what all of this means. Okay, so we'll get through this a little bit in this chapter and a little bit in the next chapter. But to make it less intimidating, I wanted to point those out first. So you can practice this back and forth. That's the easy way. So you pause the recording, you go through your PowerPoint, and you just write it out. And then eventually the words become words that you can kind of grasp a little bit more. And then here is the same P to A view, but by the same author. So this is from the theme book. Again, showing trigeminal nucleus, a lot of real estate happening here. Okay, principal, nucleus, and then the nerve here. Tri, right? So it's 3, trigeminal, 3. Okay. 3 even has 3 little things there. All right, so we could see some of the nucleus up this way as well. So just giving you a different picture, just like we do with x-rays, right? We don't really know what's going on until we see both views, a lateral and an AP or a PA in this case. So we could see, I'm going to erase some things here as well. So we could see superior colliculus up here, inferior below it. That's where we are. We can see our ocular motor nerve here. You can see the trochlear nerve. So the nucleus here, I keep saying nerve, but that's where the nerve is going to come out of. So this is the nucleus. So remember, nucleus just means cell body of that nerve. And we can see trigeminal motor nucleus here. So motor coming out through here. Sensory is way bigger, right? So it's sensory for the whole face. Motor is just a little guy there for muscles of mastication or chewing. You can see the nucleus of the abducens. Oh, oops, not over there. Let's erase that. The nucleus of the abducens nerve here. Okay, and then the axon coming out that way. We see the superior salivatory nucleus in blue right here, inferior salivatory nucleus below it. We see nucleus ambiguous. We'll get to all of these specifics in a minute. Dorsal vagus nucleus here. Okay, so dorsal vagal nucleus. And then look at the nucleus of the accessory nerve. Okay, and then how that accessory nerve comes out from these areas and then is guiding the control of SEM and upper trap. Good. You can see the nucleus of the solitary tract here. It's not solitary. It's got a lot going on with it. And we'll look at the specifics in a little bit, but you can see them coming all the way up. Okay. And then vestibular cochlear is in yellow on this side here. A little bit of here. Okay. All right, I'll erase some of this for you. And here's your practice for it. So to draw it is to know it. There's actually a program out there called To Draw It Is to Know It. So that's how many times we say that in anatomy and physiology, that there's actually a program out there that helps you draw things. So check that out if that's of interest to you, or just use these. Number 3, integrative functions. So a number of integrative functions are organized at the level of the brainstem. So complex motor patterns, multiple aspects of respiratory and cardiovascular activity. So anything going on with the brainstem here, specifically the medulla, we think of that as the major control center for cardiovascular and respiration. So we want to make sure that that's nice and healthy. Regulation of levels of consciousness. So this is going to be the reticular formation in charge of this. You might see it abbreviated as LOC, levels or loss of consciousness. LOC would be loss of consciousness. And then reticular formation. So reticular formation forms that central core of our brainstem. So we can see our picture here, starting at the bottom up, our medulla, and then the circle here, pons, midbrain area here, We can see our thalamus here. We can see the cerebrum or the cerebral cortex, and then the cerebellum back here. Okay, so front, back. I'll write some of that for you. And let's look at this here. So there's that cerebral aqueduct, and then the fourth ventricle. So each of the three major subdivisions of the brainstem, medulla, pons, midbrain has a characteristic set of surface features. So what we'll see a little bit later, so it'll be explained in subsequent sections, knowledge of these surface features can help make sense of this internal organization of the brainstem. Here's a picture for you. And another one here for you to kind of keep fleshing it out. So remember up here, superior colliculus, inferior colliculus, cerebral aqueduct. So this posterior aspect here, we can call that the tectum. Okay, so tectum. Okay. There you go. This more anterior area would be the tegmentum. Okay, so tectum in the back also kind of rhymes with something on the back side of people, is how I remember that one. And then tegmentum in the front. I don't have a rhyme for that, but it's obviously not tectum. So, and then pons. Okay, basal pons, pons. We just call it pons. Just like we call medulla, medulla oblongata. Okay. And then fourth ventricle right here. Great. And this picture here from Theme, I really like Theme's artwork. It helps with understanding things, I think. So go through here. Here's our peduncles. There's the middle one. That's always going to be the biggest one that we see. Here's superior or superior cerebellar peduncle. Inferior, a little bit lower. So you can see that there's really no distinct line that we can see very easily in these between the middle, superior, and inferior. So when I'm in the lab, I always just pin the middle one because that means that you've been to lab and you know what's going on. And you know that I'm just going to pin the middle one because it's the biggest one. And then we differentiate what information is coming in where when we look at this in lecture and the understanding of it. So let's go ahead and start at the top, superior colliculus, inferior colliculus. Here's trochlear nerve coming around, only one that comes around from the back side and goes towards the front. Okay, so he's coming around from the back, going towards the front. I'm betting this is trochlear here on the other side. It's remember, all of our cranial nerves are bilateral and symmetrical. We can see trigeminal here. Okay, so the big one is the sensory. The little guy is motor. So remember, motor is just chewing. Sensory is all of the face, the three aspects, B1, B2, B3. And what do we see next down here? We could see vestibular cochlear, this little guy. Okay, then we could see facial nerve. We could see abducens. We could see glossopharyngeal right here. And then we could see vagus coming out right here. Okay, so vagus right here. And then we see hypoglossal or 12 right here. And then look at this guy, C1, spinal nerve right there. All in the mix with, here's accessory. Okay, so cranial nerve 11, upper trap, and SCM. So look at what that C1 nerve is, how close that is to this whole mix right here. Yeah. And here's the blank one, so you can go through this. So go ahead and pause and make sure you can do that. And the PDA view again. And so adding a couple things in here. Okay, so we know our good buddy, the corpus quadrigemina, superior colliculi, inferior colliculi. Trochlear nerve is that kind of mustache for inferior colliculus at this point, right? And then cruising around towards the front, we could see the rhomboid fossa of the floor of the fourth ventricle here. Point out a couple of things here. Okay, so I'm going to erase over here, but looking at the bottom aspect of the floor of the fourth ventricle. So trigone of the vagus nerve. Okay, so right here, see how you could see this V-shaped right here? That's how I remember that one. Okay, so vagal trigone. And then we could see right above that, so it's still a V-shaped here, but when I see this in my mind's eye, I see a V here, vagal trigone, and then I see the next one up here, I just see an H for hypoglossal. If that helps you, cool. If not, there you go. It's easily erased. So we see our vagal trigone and our hypoglossal trigone. So remember that these are the cranial nerves. Okay, so vagus 10, hypoglossal 12, facial colliculi right here, and stria medullaris. So I want to point those out at this point. You can see the vestibular area over here. Who else do I want to point out? I think that's about it of the main ones. Oh, we could point out pineal gland here. So remember pineal gland. So that takes, basically converts serotonin, methylates it into melatonin in response to darkness to help us sleep. Some people will supplement with melatonin to help them sleep. And you could use this for your studies. And first things first, where are we? We could see the obvious markings of the pons here. So this is medulla, and we could see the obvious markings of the pyramids of the medulla right here. And then the ones further out would be the olives. So then we've got our pons, our medulla, and then this would then be midbrain. Okay, so I'll erase this. So we could see here ocular motor nerve. Okay, so little ocular motor nerve, cranial nerve 3. We could see our cerebral peduncles. Peduncle just means stalk, so the cerebrum is going to be held on by the cerebral peduncles, basically. Not really held on, just kind of connected into here. There's a lot more holding it on than that. And then this fossa, okay, so this little divot here, interpeduncular, in between the peduncles. All right, so these are the peduncles. This is the interpeduncular fossa. Easy when we start to break down the words, right? Then we see our pons, and then we could see that big old trigeminal nerve. Sensory is bigger than motor. And abducens right here, 6. So cranial nerve 6 right here. So we could see this 7, cranial nerve 7, and this nervus intermedius, and we'll define that in a little bit. Cranial nerve 8 is here, cranial nerve 9. Okay. And then where is our vagus? Right here. So vagus 10, hypoglossal 12. So note, these are our pyramids, and these are our olives. So in that line between pyramid and olive, what nerve comes out from there? Yes, cranial nerve 12, hypoglossal. And then you could see spinal accessory and how that is here. And then again, pointing out cranial, not cranial, cervical, C1, cervical nerve 1, right there, C1. Look at that, how much in the mix that is in the brainstem. Okay? And then we can see the decussation of the pyramids. So see this right here, where the pyramids cross over. So our pyramidal tracts, remember cortical-spinal tract, so coming down from the cortex, so think motor homunculus band, and then cruising down those pyramids. And then we see the crossing over happen here. Okay, so cortical-spinal tract. Okay, so it doesn't necessarily take these little squiggly lines here. I'm just not a good artist. Okay, so coming down from the cortex. Okay. And remember, a small amount does go same side. And a small amount does stay on the same side here. And you knew that was coming, right? So go ahead and pause that and practice with that. What was that nervous intermedius of 7 that I just mentioned there? So it innervates the lacrimal, submandibular, and sublingual glands. So lacrimal means what? Tears, exactly. Submandibular and sublingual, that's going to be saliva. So think of the secretions of the face. Okay, so lacrimal, tears, submandibular, sublingual, saliva. The afferent or sensory component of this nervus intermedius carries sensory perception from the skin of the external auditory meatus, which is that ear hole basically, and from the nasopharynx. So where the nasopharynx, that's that little hole in the back. So think of the eustachian tube on how that links the middle ear to the nasopharynx. Okay? So nasopharynx and nose, and taste from the anterior 2/3 of the tongue. So sweet, salty, sour, not bitter. Bitter is back 9. Floor of the mouth and the palate. And you can check out more if you want to know all about that at this article that I cited for you. This is the picture that Nolte gives us. You can check this one out. I was not a big fan of trying to identify it from this picture. Trying to take away the letterings on here, just kind of left it with a bunch of blanks. So not what I wanted to try and make sense of for class here. But one of the things here I do want to point out is the orbix. It's this opening here. So we have our vagal trigone, our hypoglossal trigone, and then the orbix is the opening. O for orbix, O for opening. I pretend that that's symmetrical in a nice circle there. And that is going to be our cerebrospinal fluid going down and becoming the central canal there. So you could see all of these same structures that we just saw, but what they might look like in reality. You could see the pyramids, you could see some of the cranial nerves. So I'm going to go ahead and pause there if you like. Just giving you a little bit of where you are in space here. So this is dividing up what we call caudal medulla from rostral medulla versus caudal pons, rostral pons, caudal, rostral. So just kind of breaking it up in halves, and which one's towards the tail and which one's towards the nose. Okay, so caudal towards the tail, rostral towards the nostril, exactly. A little bit of the internal structures of the brainstem. Okay, so it reflects our surface features and the position of some of these long tracts. So we can see over here, the inferior olivary on the left, inferior olivary nuclei. That is one of the things that we look for first when we're just trying to get our bearings here. Right, so if this wasn't labeled, you could see that this would stick out, right? So this kind of dentate looking structure. That's the inferior olivary nucleus. I know I'm in the medulla when I see that. And then looking to the right, you can tell that that's the basal pons just from no inferior olivary nucleus. Right? And then you can see that fourth ventricle up here. And then looking over here, we can tell this is midbrain because we can see the cerebral aqueduct, the periaqueductal gray area, and these two familiar bumps of the superior colliculus, dead giveaways of midbrain pons medulla. So our corticospinals here coming through, we want to remember that this is going to be medulla. Okay, so this medulla area here. The pyramids of the medulla is where this guy is crossing over right there. Okay, so obviously it comes all the way through the entire brainstem, but the crossing over happens at the decussation of the medulla. Okay, so corticospinal tract and the anterolateral system, ALS, coming up, remember, so that is ascending, so that's going to be our spinal thalamics, really. So they have this consistent structure throughout here is all that's reminding us. Another picture here so you could see what we're just looking at there. So again, remember we saw the superior colliculus telling us that that was midbrain and the cerebral aqueducts. And then we saw aspects of the pons cut through here And then we see aspects of the medulla cut through as well. And that's from Nolte as well. So see how this is kind of chaotic with all of the abbreviations, and I didn't think it was very clear for testing purposes, but it's nice for realistic purposes of labeling, I think. Another viewpoint here, so this is from the Marib anatomy book. So I won't test you from this, but if you were just trying to piece it together and you like this picture better, go for it. So this slide is also color-coded for us. You could see the cerebral peduncles, also known as crus cerebri in blue over here. Remember, everything is symmetrical and bilateral. Okay, so just showing you one side here so you can kind of see what it would look like in reality on the other side. Interpeduncular fossa in between the peduncles, fossa there in green. The optic tract cruising around the top area here, so that's kind of put in. And then ocular motor nerve is also drawn in yellow. A little bit of the extension of the trochlear nerve is drawn in red there. And then you can see the mammillary bodies. There's some mammillary bodies here. Looking at the pons here, we could see the basal sulcus in green, so that would be where the, so you could also call that the basilar groove, this area right here. So the basilar artery, so remember our circle of Willis, right? We have our basilar artery and our vertebral arteries. So V for vertebral right here, right? So this would be the vertebral arteries, and they become the basilar artery, and then it's in this groove right here. Trigeminal nerve is in blue over here. Abducens is yellow over here, facial, vestibular, cochlear. And who's on the ventral surface of the medulla? We could see the pyramids in green here. The olives are in blue over here. This right here is the olive. You can see the decussation of the pyramids would be right here in this orange. We saw where that crossed over. You can see the ventral median fissure, so this just means it's on the ventral aspect, it's in the middle, and it's a little crack. That's all that means, that line right there. All right, so mine, okay. Glossopharyngeal nerve, you could see that right over here, if you can, there you go. Vagus is in purple. You could see the accessory nerve drawn in here, and then coming down that way. And then hypoglossal in between that olive and pyramid. Trochlear nerve, you could see that bright yellow guy right there. Yeah, so the little mustache of inferior colliculus, superior colliculus. Together we call it corpora quadrigemina. So if you note, right, so corp being body, quad being four. Okay, so we've got those four little circles there, is all that's saying. So we could see the bigger one is the middle cerebellar peduncle here, okay? Superior and inferior. Okay, so this is the dorsal surface of the pons. We could see the facial colliculus in red, and then that anterior medullary velum area, so just this little guy right here, that area right there. And our medulla dorsal surface here, so we could see fasciculus gracilis and fasciculus cuneatus, and then the tubercles, kind of where they end up here. Okay, so fasciculus gracilis, fasciculus cuneatus of the dorsal columns, and then their tubercles. Let's see gracilis tubercle noted here, but get the idea. So gracilis is medial and cuneatus is lateral. You can see the clava in that light blue. Obex, the opening right here in red, remember? And so we had our vagal trigone, hypoglossal trigone, and the obex, remember. And then the stria medullaris is just this purple area right there. Things to note, cranial nerve 4 is the only one to exit the dorsal surface. We've said that a bunch of times. I'm going to say it a bunch of times in chapter 12 as well, so make sure you don't get that one wrong. It shows up on the boards all the time. It shows up on my tests as well. Cranial nerve 12 exits between the olive and the pyramid, so make sure you pick cranial nerve 12 when you get asked who is exiting between the olive and the pyramid. Looking at a slice of the caudal medulla, we could see the fasciculus gracilis in this light blue area up top. And then you can see the darker blue in the middle of that light blue. That's the nucleus gracilis. Remember, nucleus just means this is where the cell bodies are. We could see fasciculus cuneatus, so the upper extremity aspect of the dorsal columns. This is the lower extremity aspect of the dorsal columns. And then it's cell bodies here, nucleus cuneatus. You can see the brighter yellow. You can see the pyramids. Remember, pyramids are going to carry corticospinal information, and then the decussation is where they cross over. See in orange the spinal tract of the trigeminal nerve. You can see the spinal nucleus of the trigeminal nerve in red. We could see nucleus gracilis, nucleus cuneatus here a little bit easier, and we could see the accessory cuneate nucleus, internal arcuate fibers. All of these are color-coded for you here to make it a little bit easier. Hypoglossal nucleus, so remember this is going to be 12, cranial nerve 12 nuclei, so the cell bodies to cranial nerve 12 are from cranial nerve 12. Inferior olivary nucleus in that lighter green, darker green is going to be pyramid, and here you could see the reticular formation in purple. Circle that for you here, see the reticular formation. We can see the fourth ventricle here, so we could see that this is the rostral medulla by the size of this fourth ventricle. You can see the inferior peduncle, cerebellar peduncles here, so remember there's a superior, middle, and inferior cerebellar peduncle. The middle is always going to be the largest, but we could see some of the inferior here. Hypoglossal nucleus is in red. Dorsal motor nucleus of vagus in blue here. Vestibular nuclei is in orange here. Nucleus ambiguus, yellow. Okay, ambiguous is going to be 9 and 10. Okay. My mnemonic for that is ant. Okay, so cranial nerves 9 and 10 are going to come through here as well. Solitary tracts in the upper light blue area. Inferior olivary nucleus is going to have that kind of dentate appearance to it. And then the pyramid, so corticospinal tract goes through these pyramids, remember. Caudal pons, so caudal again meaning towards the tail. Big pontine nuclei in this yellow area here, and the middle cerebellar peduncle, the biggest one being the blue guy right there. We could see a little bit of the fourth ventricle. Here we're seeing it as cerebral aqueduct up here. This is a little higher up, Okay. And then you know how this goes here. We see our trapezoid body here in orange, color-coded for you. Superior olivary nucleus in this light green area over here. Facial nucleus in red, vestibular in the lighter blue area here, and abducens nuclei. I'll erase some of that so you can see it. Rostral pons, so again, orient yourself to the fourth ventricle space here. You can see superior cerebellar peduncles. Note that everything is bilateral and symmetrical. Trigeminal nuclei, we can see reticular formation, purple dots there again. our middle cerebellar peduncle, and the pontine nuclei. Another picture of the rostral pons here for you. So we could just see these pontine nuclei kind of interspersed through here. Midbrain at the level of the inferior colliculus, so the little bumps here of the corpus quadrigeminal. Remember, we have superior and inferior. Inferior being auditory reflex. You hear something out of the ordinary, you turn and you look. That's inferior colliculus. Managing that. Trochlear nucleus, so cranial nerve 4's nuclei, you could see it right there in yellow. Okay, remember these are bilateral and symmetrical. Periaqueductal gray around the aqueduct. Okay, so the gray matter around the cerebral aqueduct here. Lateral lemniscus, okay, so just this little ribbon here. Okay, little ribbon here, lateral lemniscus. Reticular formation, you can see the purple dots. Substantia nigra is this blue area here you could see, so really means black substance. Okay, so dopamine production here. It's pale in Parkinson's disease, remember? Decussation of the superior cerebellar peduncle at the lighter green area, so you could see that light green in here. And then the crus cerebri is the darker green. Again, crus cerebri in darker green here. Substantia nigra here. You can see the red nucleus now. Reticular formation, periaqueductal gray around the cerebral aqueduct. Now erase it here so you could see the Edinger-Westphal in the brighter yellow and the orange for the ocular motor, and then we're here at the level of the superior colliculus. Superior colliculus. Another picture here from your book, so you can kind of take a look at that. You can see medial lemniscus here. Spinal thalamic tracts coming in. You can see substantia nigra, the compacta part, and the reticular part. So this is a diffuser tensor image of the lateral view of the brainstem. So kind of a neat looking picture, I think. So these are those functional MRIs. So to orient you here, you could see the thalamus in yellow up top here. Okay. And then these fibers right here are the pons going back, and you could see the cerebellum here. Kind of a neat picture here, I think. You can see how big these middle cerebellar peduncles are here. Nice view of medial lemniscus, so that's in yellow right here. If you can see my cursor moving, kind of neat. Let's look at the blood supply. So the medulla, we're going to see vertebral artery branches, anterior spinal artery, and posterior inferior cerebellar artery are going to be the main branches for blood supply. So remember, our vertebrals come up, and then we see our basilar, and then we see our little circle of Willis guy. And so vertebrals are here. Anterior spinal artery is going to be that guy right there. And so this guy right here. I'll go for yellow. Anterior spinal. Good. I'll erase this. Then we can see the little pontine branches off the basilar, so I'll go for green for basilar in the picture over here. So basilar right here, and then the little pontine arteries off to the side here. So remember, there's that basilar groove in the pons, that little divot. So we have pontine branches, and then we have ICA, anterior inferior cerebellar artery, right there. Okay. Good. Midbrain, we're going to see superior cerebellar artery. We'll go for a darker purple here, so superior cerebellar artery. This one is from your book, so you could see exactly where the blood vessels are responsible for. So this brings us into our rules of force. So this is a way to learn and understand and compartmentalize or file the information of the brainstem in your memory. So we have this rule of fours, and it was a paper published in PubMed by Gates, and Gates was a neuroanatomy professor and kind of came up with this rule of fours, published it, and it's used all over the place. And I still use it. My mentors still use it in order to keep things kind of straight and easy to recall. So let's look at it. Rule fours. Okay, so we're going to break this slide apart in bite-sized pieces. So this is just the overall that you can kind of go back to. So the outline, if you will. So the rule of fours, we've got 4 rules of 4. Okay, so 1, 2, 3, 4 here. And then we're going to look at deficits as well. Okay. So our cranial nerves, we're going to be able to break them down into midbrain, pons, medulla. There's 4 cranial nerves that are going to be medulla, pons, midbrain, and above. So 1 and 2 are not in the midbrain. So this is really just midbrain and above. Okay, a little caveat here. Okay, little star. And then we're going to see 4 midline structures that start with M. We're going to see 4 side or lateral structures that start with S. We're going to see these 4 cranial nerves that I just explained here. 4 in the medulla, 4 in the pons, 4 in the midbrain and above. And then our 4 motor nuclei are divisible into 12. So 3, 4, 6, and 12 are motor and they're medial, meaning 5, 7, 9, and 11 are sensory and to the side. Now, I don't expect anyone to get this the first time out. If you do, great, but most of us don't get this the first time out. We have to look at the next couple of slides and look at it a couple of times until it starts to make sense. Okay. So what do we mean by these 4 medial structures that start with M? So motor tract, that's going to be corticospinal tract. Okay. And we're going to see opposite weakness on the arm and leg when we see a deficit here. Medial lemniscus, so remember the DCML and spinal thalamics as well, but spinal thalamics usually doesn't get mentioned for some reason when we talk about medial lemniscus. So medial lemniscus, dorsal columns, we're going to see opposite side vibration and proprioception of arm and leg becoming a problem here if there's a deficit. The MLF, okay, same, so MLF, medial longitudinal fasciculus, same, look left, but right eye stays straight or vice versa. So this is yoking vision together, remember, MLF. So yokes that's 3 and 6, cranial nerve 3 and 6 together to make the eyes look in the same direction at the same time. Motor cranial nuclei divides into 12. So 3, 4, okay, moves the eyes. 6, moves the eyes. 3, 4, 6, and 12. Those are all medial. 4 side structures, what were those? Let's erase some of this so it doesn't look so crazy. Already looks a little intimidating, but it'll make more sense. We'll flesh it out, I promise. 4 side structures, so sympathetics, spinocerebellar, spinothalamic, and sensory 5. Okay, so trigeminal. So sympathetics, we're going to see a same Horner's syndrome from this area here if there's a deficit. So we're going to see the mnemonic PAM, remember, so ptosis or drooping, anhidrosis, not sweating, and meiosis or constricted pupil. Spinocerebellar, same ataxia in the arm and leg. Spinothalamic, opposite pain and temperature in the arm and leg, so that's going to be off to the sides, remember. And then sensory, same side, face sensation. So we're going to see same S for same, shaky leg, Horner's, okay, facial sense, opposite, pain and temperature. Okay, spinal thalamic opposite. So let's make this make sense, shall we? All right, our rule of fours, there's Gates paper being cited at the bottom there. This is a commonly used PowerPoint that is free and for public use. So I didn't make this. It's the PowerPoint that goes with Gates's rule of fours. So again, here's our rule of fours. Number one, 4 structures in the midline that begin with M. Number 2, 4 motor nuclei in the midline that are divisible into that 12, remember. So we're looking at that 3, 4, 6, and 12. We kind of ignore 1 and 2 when we're looking at this because 1 and 2 are not in the brainstem, remember. Number 3, 4 structures to the side, lateral, and begin with S. And then our 4 cranial nerves in the medulla, 4 in the pons and 4 above the pons. That to me is the easiest one. That's the one that we want to really remember. It's going to help us localize these lesions really just easily on if we're in medulla, pons, or midbrain. And most people get this one the quickest, and then the rest of it starts to make sense a little bit later. So let's look at rule number 1. Okay, so our 4 medial structures. Our motor pathway, what's our motor pathway that we think of off the bat? Yeah, corticospinal tract, very good. Medial lemniscus, okay, so DCML, medial lemniscus is going to be into this area. Medial longitudinal fasciculus, or the MLF, and our motor nucleus and nerve. So part of this motor versus sensory, remember our sulcus limitans. So I pulled this slide out from chapter 2, right? So that's sulcus limitans. So in the brainstem, the alar plate will be more lateral than the basal plate. Basal plate is going to be motor nuclei. So motor nuclei are going to be medial to the sulcus limitans, and the sensory nuclei are going to be lateral to the sulcus limitans. Okay, so here's the M's, and here's the S's here. Okay, so motor nuclei, MLF, medial lemniscus. You can see the inferior olivary nuclei here. Good. 4 medial motor nuclei, so those cranial nerves dividing from the number 12 here, so 3, 4, 6, and 12, midline. 3, 4, 6, and 12, midline. So then 5, 7, 9, 11 are lateral. So when I memorize things that have, 2 things like this, I just memorize the 1, 3, 4, 6, and 12, midline. And then if I see the other ones, it's the opposite. 4 side structures that start with S are spinocerebellar, spinal thalamic, sensory nucleus of 5, so trigeminal, so sensory for face, remember. And then we see the sympathetic pathways, sympathetics, so that's where that Horner's deficit shows up, remember. Horner's can show up from a multitude of reasons. So we can see a little picture here for our 4 cranial nerves in the medulla, 4 in the pons, and then midbrain and above. So sometimes the nuclei are really large, so think trigeminal, remember, okay? And they're going to span more than one area, so we kind of want to remember that when we're looking at this. And then some of the nuclei are going to have more than one cranial nerve, is like solitary and ambiguous, things like that. So this is how I do it because I don't think in Roman numerals. I like these Arabic numerals or numbers here that we use and see every day. So all I do is I write out my 12 cranial nerves, 1 through 12, and then I separate them out and then write medulla, pons, midbrain, and above. Nice and easy. So if we see an issue with something that is cranial nerve 12, tongue, right? That's medulla. We see an issue with something that is facial nerve, that's pons, right? Or 6 or 5. And then if we see 3 or 4, that's going to be midbrain. So that's how we're going to localize the lesion or the deficit in our patients and in the academic world of this is how we test the anatomy, kind of pull it all together. Now, are we going to really be localizing the lesion during a stroke? No. But for rehab, yes, absolutely. This is helpful in rehabilitation for our patients. So the next couple slides here looking at their deficits, Rule 4 and their deficits. So again, this cross section here, you can see the M's in the middle and the S's on the side. So let's look here. The 4 medial M structures and their associated deficits are the motor pathway. We'll see a contralateral weakness of the arm and leg. We see this in stroke all the time. Medial lemniscus, we're going to see contralateral loss of vibration and proprioception in the arm and leg. Dorsal columns. Medial longitudinal fasciculus, we're going to see same side, ipsilateral, internuclear ophthalmoplegia, or what we call INO. Okay, so same side INO. So between that 3 and the 6, there's a miscommunication. There's not enough good connection there from the MLF. So we're going to see a failure of adduction of the ipsilateral eye towards the nose and nystagmus, so those kind of wiggle waggles in the eyes, in the opposite eye as it looks laterally. Okay, so failure of adduction of the same eye towards nose, and nystagmus in opposite eye as it looks laterally. INO. Number 4, the motor nucleus and nerve. So ipsilateral loss of the cranial nerve that is affected. So that's the 3, 4, 6, or 12. Okay, so 3, 4, 6, or 12 deficits. Our side structures. So spinocerebellar deficit, we'd see same side ataxia of the arm and leg. Spinothalamic, we're going to see contralateral alteration of pain and temperature affecting the arm, leg, and rarely the trunk. Sensory nucleus of trigeminal, we're going to see same side alterations of pain and temperature. Okay, spinothalamic and sensory of 5. So remember, trigeminal is really similar to spinothalamic, but for the face. Sympathetics, we're going to see a same side Horner's syndrome. So PAM, ptosis, anhidrosis, and meiosis. These pathways pass through the entire length of the brainstem and can be likened to the meridians of longitude, where the various cranial nerves can be regarded as parallels of latitude. If you establish where the meridians of longitude and parallels of latitude intersect, then you can have the established site of the lesion. So just like the Earth, right, with our GPS. So if we figure out where we are, so the cranial nerves is really the way we do this longitude, right? So that's super easy. We just write out our 1 through 12 and then divide it out, right? And so this is medulla, and then the next 4 are going to be pons, and then if we see 3 and 4 involved, we know that's midbrain. That's how we're going to divide this out. And then those medial and lateral rules, or midline and side rules, are going to let us know, is it a midline medullary stroke? Is it a midline pons, midline midbrain? Or is it lateral? And so we're just going to look up and down. Cranial nerves are going to tell us that, medulla, pons, midbrain. And then our midline or lateral rules, medial or side rules. Okay, so our cranial nerves here, you can see 1 is right here, 2 is right here. Okay, 1 nose, 2 eyes. Cranial nerve 3, We've got 4 and 6. Okay, those are more midline. Of course, kind of lateral for midline, but we still call it midline. A little dividing line. Creative line there. Let's look at these cranial nerves here. So our 4 cranial nerves above the pons, or midbrain and above. So 1 and 2, 1 nose, 2 eyes, not in the midbrain, not discussed in the brainstem here. Ocular motor, cranial nerve 3. If we see a deficit here, we're going to see impaired adduction, supraduction, infraduction, everything that cranial nerve 3 does. So cranial nerve 3 controls all the eye movements except for lateral rectus is 6, superior oblique is 4. Everybody else is cranial nerve 3, including pupil. Cranial nerve 4, we're going to see the patient, the eye is unable to look down when the eye is looking in towards the nose. So cranial nerve 4 is notoriously tricky. I highly suggest you go to the eye movement simulator link on your website there in order to really get an idea for this. But basically what we do is look at your finger. Okay, so hold your finger out in front of your face and then bring your finger in towards your nose. You are testing this SO4. Okay, so if there's a problem with that, there's a problem with the SO4. And then the way I like to deal with that problem is not do these pencil push-ups so much. So that's traditional, and that's what I first learned, but then that's kind of frustrating for the patient. And the idea here would then be to sneak in the side door of the VOR, or the vestibulo-ocular reflex. So instead of bringing your finger in towards your nose over and over again and getting diplopia and nauseous and aggravating the patient, and then the patient not wanting to do it, do the VOR instead. So focus on something far away. Hold your eyes on that focal point and then turn your head. You're still going to activate that same muscle. Okay, so you're still going to activate that SO4, but you're going to get in from a different pathway. And then that will help facilitate that SO4 connection. Okay, so use that as your first line of rehab, the VOR. Number 5, trigeminal, ipsilateral, or same side, alteration of pain, temperature, and light touch on the face. So remember, 5 is kind of like spinal thalamic, but for the face. Number 6, abducens, same side weakness of abduction or lateral movement of the eye. Number 7, facial. So facial nerve, you're going to see same side facial weakness. 8, you'd see same side deafness. Medulla, 9, 10, 11, 12. 9, glossopharyngeal, you're going to see same side, loss of pharyngeal sensation, so kind of throat, so think gag reflex. 10, we're going to kind of lump 9 and 10 together for gag reflex, and then 10, you'll see more specific ipsilateral palatal weakness and uvula deviation. 11, spinal accessory nerve, we're going to see same side weakness of the upper trap and SCM. 12, we're going to see hypoglossal, so this is going to be same side weakness of the tongue. So the tongue is going to deviate towards the lesion for the tongue. So a medial brainstem syndrome is going to consist of the 4 M's, or any combination of them, and the relevant motor cranial nerves. And a lateral brainstem syndrome will consist of the 4 S's. And then you localize it to the cranial nerves, if it's medulla, pons, or midbrain. Couple notes here that you want to remember. All cranial nerve deficits are going to be on the same side, except sight is all over the place. So it's a different chapter. You don't have to know what that picture means. That's in reference of it's complicated. So there's some that's same side, some that's opposite side, and that's a totally, it's a separate lesson in and of itself because of its complications. We're going to use the visual field deficits for that, and we'll learn that in another chapter. So a couple of things that get commonly confused because they're very subtle differences. So vertigo is specifically your head or the room is spinning. And we use the word disequilibrium when the patient says their balance is off and they might fall. Okay, so a couple of just random notes and vocab here that we want to make sure that we are understanding as you're reading through the chapters. I threw this chart in here for you for your cranial nerves because we're going to get into cranial nerves next chapter, so you can look at this for the where the cranial nerves exit. And so, cranial nerve exit here. Congratulations, you made it through chapter 11. You made it through quarter 2. Good job. Make sure you check out your website and do the activities there. And I'll see you for the final and for quarter 3.